Good afternoon. Welcome, everybody, to our first webinar in our 2020 Leading with Evidence series. Today, we will be discussing ways in which a preventive practice model can contribute to meeting some of the conditions put forward by the Family First Act. I'm Suzanne Barnard, the Director of Evidence-Based Practice at the Annie E. Casey Foundation, and I will be your moderator today. The Annie E. Casey Foundation, in partnership with the William T. Grant Foundation, is in our 5th year of co-sponsoring the Leading with Evidence series of convenings and webinars. Our aim, as always, is still to offer practitioners and researchers ways to immediately apply programs and practices to gain more clarity and strengthen the utility of our work. Today, though, I'd like to start this webinar by acknowledging that in spite of these extraordinary times we find ourselves in, so many of our colleagues, while facing huge challenges, continue to make heroic efforts to meet the needs of the children and families they serve. All of us have heard stories of child welfare workers stepping up to mobilize resources and increase protections for others, all the while putting yourselves on the line in service of others. I want to give a huge shout out to all of you in child welfare for all that you do and for carving out the time to even listen in on this presentation today. Frankly, we at KC discussed what we would even talk about, given that what would have been considered normal practice is not normal anymore. We already know that there will be long-term challenges to the field, and some of you are already developing innovative approaches and reimagining how you will fine-tune your vision to create a clear pathway to prevention. So today we decided that our webinar will be a little different, and that we would focus on helping you think about how you might use your practice models to mitigate the conditions that you've been given. We will start the first part of the webinar with a presentation on how you might use a practice model to make sure programs are ready for the current times, that they are implemented equitably while incorporating family voice, and that they are in accordance with your fiscal resources for using available evidence within the requirements of Family First. Then we'll transition to a real-time interview with a voice from the field to give us a picture of how one child welfare leader is rising to meet the challenge in her system while still pursuing the reforms that she wants to put in place for the future. Our speakers for this presentation today are Allison Metz, the Director of the National Implementation Research Network at the University of North Carolina. She will be joined later in the presentation at the question and answer portion by her two colleagues, Leah Bartley and Amanda Farley, also from NERN. Our second speaker is Jacqueline McKnight, Deputy Department Director of Child and Family Services in Mecklenburg County Department of Social Services, North Carolina. I want to take a moment to go over some important housekeeping details, though, for this webinar. After we hear from our presenters, we will have some time for questions. We'll need to keep our attendees on mute, though, throughout the webinar, and we ask that you submit your questions by entering them in the Q&A window, which you see circled on the slide. You'll find that window lower right-hand corner of your webinar screen, and you can submit a question there to the panelists. If you are in full screen mode, and you want to ask a question, you may need to return to the event window by using the drop-down controls at the top of your screen. I will also mention that this presentation is being recorded, and the recording and slides will be available later at aecf.org. And with that, I'd like to turn it over to our first speaker, Allison Metz. Hey, Allison.
Hi, Suzanne. Thank you so much for that introduction.
You're welcome.
I think we're ready to move forward with the first part, so we can move to the next slide. Before we jump into talking about the preventive practice model for child welfare that Suzanne just mentioned, just wanted to draw attention to the fact that this paper can be downloaded at the Annie Casey Foundation's website. You can see the link there, and that'll be made available to everyone participating today. And we encourage folks to take a look at the full paper. What we're going to do now is walk through some highlights from that, and then, as Suzanne said, move into a discussion. So the purpose for developing this paper was for us to provide guidance to state child welfare agencies on what they may want to consider when developing a preventive practice model that will align with requirements of Family First, that will address the needs and strengths of families within their local communities, will help ensure that the programs and practices that they select to implement are feasible to implement and that they can do so with quality. And that while we know that primary prevention plays a critical role in supporting families and reducing child maltreatment, this preventive practice model focuses on families who have come to the attention of the Child Welfare Agency and where the child is deemed a candidate for out-of-home placement in alignment with the Family First legislation. We used a methodology to develop this practice model, and again, you can refer to the full paper for more detail on that. But we wanted to note that we convened a design team in developing this practice model because we really felt that diverse perspectives were critical in understanding not only what the best practices would be to developing a preventive practice model, but what we would need to consider to implement the model with fidelity and quality, and also to ensure that family voice was included and that we could seek improved and equitable outcomes in prevention services. So the design team that we brought together included child welfare leaders, purveyors of evidence-based programs, and experts on policy development, public systems, research, equity, and inclusion. Planning is underway for next steps in refining the preventive practice model, which will include focus groups with youth and families to get more of their perspective into the practice model. And as I noted, that is underway currently. Our goal in developing this was to develop a framework for serving families with children at risk of placement and moving away from what we typically focused on, including compliance, case monitoring, and provision of available services, and moving towards an evidence-driven case management process that allows us to have a comprehensive understanding of a family situation and to provide the right services to meet each family's unique needs. We see evidence-based case management as the foundation for the preventive practice model, as we see it promoting stable and trusting relationships with families. And having these trusting relationships will allow caseworkers to understand what changes in behavior are needed to prevent placement, how to support families who have immediate needs through targeted services that can reduce risk factors and enhance protective factors, and then to consider whether families can successfully engage in and benefit from an evidence-based program if needed. You'll see here in this graphic that we represent the preventive practice model, and we really see it as an overall framework for the delivery of preventive services for children at risk of placement and their families. A well-defined practice model would align three major aspects of prevention: case management, targeted services, and evidence-based models. The framework recognizes the role of primary prevention and child protection before children would be considered candidates for out-of-home placement, with the overall goal being the prevention of out-of-home placement. And you can also see that we include children and families at the center of this practice model. So as we think about evidence-based case management, targeted services, and the use of evidence-based models, we make all of those choices with children and families at the center of all decision-making. So we'll walk through now each of the aspects, the three aspects of the preventive practice model, starting with evidence-based case management, which we define as an approach supported by research evidence to working with families to understand their situation, including their strengths and needs, to develop a plan to reduce those risk factors and enhance protective factors and facilitate behavior change. The reason we refer to this as evidence-based case management is we think that case management needs to be driven by evidence in the same way that evidence-based programs are. and that it can serve as a foundation for family support. We see that there are two ways to develop an evidence-based case management approach as the foundation to this preventive practice model. You can select an established model, such as solution-based casework or family connections, or another model. Another way to approach this would be through a common elements approach, where a state may identify and develop evidence-based strategies, such as engagement, assessment, service planning, and pull those strategies together into an overall approach that is undergirded by evidence. The second aspect of the preventive practice model is targeted services. So we define these as services and supports for families that address their unique needs and meet the specific goals of their situation to prevent placement in care. We know that it's important to build the capacity of caseworkers to collaborate with families and effectively identify appropriate referrals. We can identify targeted services at two levels of the system. At the family level, we want to understand needs, risks, and protective factors for individual families, but also at the agency level, we want to assess the current service array and see whether that aligns with trends or patterns that we see related to need, risk, and protective factors. And it's really critical that as we look for these patterns, that we do so with the use of disaggregated data so that we can understand the strengths and needs of particular subpopulations that we serve in our communities. The third aspect of the preventive practice model are evidence-based models. So as you think of the Family First legislation, define this as mental health, substance abuse prevention and treatment, in-home parent skill-based and kinship navigator programs that have available evidence to support their use in practice. More information on the rating of evidence for Family First can be found in the Title IV-E Prevention Services Clearinghouse. It's really important that we consider choices that result in an array of services that address a broad range of needs. We can do so by thinking about different continuums of evidence-based models. So for example, we may want to ensure that we have evidence-based models that address different levels of risk, low risk, moderate risk, or high risk. Or we may want to have that continuum as it focuses on service type, such as mental health and substance abuse and parenting services. And then it's also really critical that we use a fit and feasibility assessment to ensure that the models that we select are culturally relevant and feasible for us to implement in our current context. There is a mention around how we determine candidacy in the paper. We would also recommend looking at additional resources, such as the Center for the Study of Social Policy has released a series of briefs around this issue and as it relates to equity. But we do want to mention that functionally defining candidacy is a challenging task, and it has significant implications for funding, race equity, and the number of children coming into contact with the child welfare system. The paper discusses how states should responsibly define candidates for foster care as children who are at imminent risk of entering care, but who can be safely served in their homes and in their communities, and to leverage the opportunity provided by Family First to develop a comprehensive prevention continuum. The paper also discusses strategic financing as it relates to the preventive practice model and the requirements of Family First. There will also be further information on that I know will be shared at the end of this webinar, where we can listen in on another webinar that will give more detailed information. We want to note that Family First is the payer of last resort. So states should begin by identifying whether Medicaid will reimburse for targeted services or evidence-based models that they include in their preventive practice approach. Title IV-E administrative claiming and training funds can also offer critical support so that we can have successful implementation. This can include fidelity monitoring, data collection and evaluation, training, assessment, and other administrative aspects of the work. Without a clear vision of the practice model, there's a risk that the funding opportunity will drive development of services. So we really recommend that we start with the practice model first, and that we put funding in place that is in service to that practice model. So we want to make sure that we are not risk the development of services that do not target the needs of families and are ineffective in reducing out-of-home placements. One of the things that's really critical is ensuring that there's an aligned system that really supports the implementation of the full preventive practice model, all three aspects of it: the evidence-based case management, the targeted services, and the evidence-based models. In order to have a cohesive model, it's really important that we consider the role of leaders. Distributed leadership throughout the state is essential in promoting buy-in and clarity in the approach that is taken and the services that have been selected in each of those three key areas of the practice model. Leaders can also ensure the preventive practice model is aligned with core values and principles, as well as other services and activities that are currently underway and will continue in a certain state. So it is really important for folks to think about those values and principles, one of which is really ensuring family voice. So we talk about how family voice is central to the work. It should be visible in all of casework practice, and it should be something that informs leadership decisions and improvements around service planning and delivery. It should be included in the earliest stages of decision-making and at critical junctions in a case. So for example, the use of team decision-making. Developing a preventive practice model, we really have to focus on behavioral change strategies that will promote better outcomes for families well beyond their involvement with child welfare. So as we consider these three aspects, the case management, the targeted services, and the evidence-based models, we want to ensure that we have effective supports in place so that we can promote behavior change strategies that will result in these outcomes. And supporting effective practice requires a visible infrastructure that will develop and ensure staff competency. So we need to think about how we are selecting and training and coaching staff, how we are assessing whether or not those practices are implemented as intended. And then we also need to be thinking about how leadership, distributed leadership, is creating policies and procedures that will allow those practices to yield their intended benefits, and that we're creating the appropriate collaborative partnerships that will ensure referrals and service delivery as seamless for families who are at risk of an out-of-home placement. So in conclusion, we want to ensure that we leverage the development of a coordinated system that can really support the use of a preventive practice model. The things that are important for us to consider are candidacy determination, how we will finance the practice model, so considering our reimbursement strategies, but knowing that we want to lead with the practice model and that the financing and reimbursement should be in service to that. That it's critical that we have systems alignment across those three areas of the practice model. At the center of that is family voice. It is one of the principles and values that should guide the development of the practice model and all decisions that are made around service delivery. And that the infrastructure that we develop to support effective preventive practices should be visible and ongoing. And in doing so, we can realize the goal of preventing entry to foster care for children and families, and that we do this through a systemic approach described here as a preventive practice model. So that is an overview of the paper. As I said, that you can get more information on. Go to the Annie E. Casey Foundation's website. But now we want to turn to an important voice from the field, Jacqueline McKnight, who is the Deputy Director of Child and Family Services for the Department of Social Services in Mecklenburg County in North Carolina. Welcome, Jacqueline.
Good afternoon, everyone. Before I get started with responding to the questions, I wanted to first begin by thanking the Annie E. Casey Foundation as well as the William T. Grant Foundation for sponsoring this webinar, and recognize Suzanne Bernard as well for her work in organizing this series on Leading with Evidence. It is an honor this afternoon to present alongside Allison Metz, who I've had the privilege of collaborating with now for about 8 years in New York City and now in North Carolina. I want to thank her for her presentation as well as her leadership in convening the design team and formulating a clear practice model.
Thank you so much, Jacqueline. And I just wanted to echo Suzanne's comments at the top of the webinar, just how inspired I am, and we all are, in the work that child welfare systems are doing every day in this new context and during this crisis, and a lot of the rapid change efforts that are going on. And we're just so grateful that you could take some time out of your day, knowing how busy it is to be with us today, but also just to know how inspired we all are by the work happening every day in public child welfare systems to do their mission critical work in the midst of this crisis. So thank you so much, Jacqueline. I actually wanted to start with a question related to that and ask you what you see as top of mind for child welfare leaders supporting prevention efforts during the COVID-19 pandemic.
So part of being a good leader is being transparent. As we were planning this session, I asked my colleagues to consider the timing of this presentation. I know firsthand the amount of energy child welfare has had to exert in transforming a safety-first, highly regulated, physically interactive system to one that is virtual in a relatively short span of time, all while keeping children safe and families supported. I must acknowledge my child welfare colleagues as they do the work in the unknown, the unpredictable, and the uncertainty realms, all which is embedded in the structure of our work daily. However, this is different. As we gear up literally with masks, gloves, gowns, and hand sanitizer to honor our missions of caring for children and families, we must pause and think about our staff, our customer, our own and our family's health and safety, even before there's a knock on the door. We have a system, as a system, we have adopted the public health framework in child welfare. And what has occurred is that it's been coupled with an actual global public health emergency. Here's the good news. We are doing it. In every encounter that I have had over the last several weeks with colleagues across the country, I have even had an international contact that suggests that we've stepped up to honor our missions while simultaneously advocating for the safety of those who are part of the work.
Wow, thank you so much, Jacqueline. It's incredible to hear a voice from the field and everything that you're doing to honor your mission and to support families. And it leads me to a second question. You were part of the design team in developing the preventive practice model, and one of the things I know that you mentioned many times in those meetings was how important it is to recognize family voice. As we were developing the model, as we continue to improve it, but also, at agency level, how it is that, family voice is really central to effective prevention efforts. So I wanted to know if you could talk a little bit more about what you're learning about engaging families during this time of crisis and how this might inform future work as you move forward and as the child welfare field moves forward from this crisis.
Yes, In October of last year, Mecklenburg County facilitated its first formal Family First Prevention Services Act planning session with our child and family serving agencies. As we developed the panel of state, foundation, and not-for-profit leaders, the most captivating voice was our 23-year-old kinship care alumni. She brought an expertise that no other panelist could. It has set the tone for how we have continued to do our work to best meet the needs of our customer. 2 weeks ago, we held an all-staff child welfare session with close to 280 staff participants. It was striking after staff shared how they engaged Sorry about the delay.
Oh, no problem, Jacqueline, at all. I'm excited to hear what comes next.
I wanted to make sure that I share it correctly. 2 weeks ago, we held an all-staff child welfare session with close to 280 staff participants. It was striking as staff shared how they engaged their assigned families in advance with pre-screening questions by telephone prior to face-to-face sessions, and it actually allowed the families to set the stage for access to their homes, either by social distancing, conducting portions of the sessions outside of the home, and use of technology such as FaceTime to view the physical structure of their home. It appears to be a more collaborative approach to assessing and accessing support, and I unequivocally support being thoughtful about utilizing this approach to our work moving forward.
That's such a great example, Jacqueline, and it is so amazing. Again, this rapid response that we see happening in public child welfare systems who have so much on their plate in the midst of this are innovating so quickly and taking this time to reflect on those innovations, and whether they're innovations just for the current time or whether they're things that we might want to carry with us moving forward, I think is a really important thing for us to consider. And so it was just such a great example around how a change now might be something we want to carry forward. When we think about, involving families and family voice, it really does align with this idea of, ensuring that the preventive practice model that we develop and the preventive services that we choose are really guided by values and principles. And I think that's something that is often kind of easy to say and harder to do. I think it's really important that we're clear about what those values and principles are, and that they really are the foundation for all of the choices that we make. So I wondered if you might talk a little bit about the principles that you are relying on to support families during this crisis, and then also similar to how you addressed the last question, whether or not there's things that you're carrying with you, or whether there's principles that feel really heightened for you right now as you are serving families.
So I don't want to minimize the impact of COVID-19 and the feelings of drowning in this very fluid environment. If we could only, as practitioners, just slightly rise above our current state, we just might have a glimpse at what is yet to come. And each one of the puns that I just shared is absolutely intense. We may not know what the impact of COVID-19 will be on the world, and particularly our system, legislatively or economically. However, what we do know is the opportunity that the Family First Prevention Services Act, in its current form, has for prevention regarding the children and families we are working so diligently to serve right now. This is really taking the what is currently being presented in the work in these present conditions as evidence to begin informing the work. As most of the states have opted to delay full Family First Prevention Services Act implementation, jurisdictions have during the interim committed significant time to plan, Mecklenburg County included. As my vision for prevention over the last several weeks have been confirmed, that we can indeed keep children and families safe and supported. However, we will not be able to do this alone. Partnering with non-traditional partners, Mecklenburg is partnering with Smart Start. It's our North Carolina early care and education provider to think through how we serve children from infancy to 5 years is essential. Partnering with our domestic violence providers, as we have seen an uptick in the number of reports that have come to our attention with regard to Family Justice Center, and continuing our efforts with establishing a Family Justice Center has become critical. And linking more and more with economic services. One of the models that we're looking at is economic mobility pathways, particularly now to ensure that these supports are part of our programming and future continuum of services. We are really being thoughtful about what best practice interventions have demonstrated good outcomes. My hope is that this penetrates child welfare in that we think about utilizing structures like the Family First Prevention Services Act to truly support our children and families' present experiences.
That's again, another great example, and it makes me think about this idea of what it takes to implement preventive services and really creating that visible infrastructure. And so these partnerships that you're talking about and non-traditional partnerships, and how critical it is to have them be visible and defined, and something that we know is critical for moving the work forward. I have a couple more questions I want to ask you, Jacqueline, but I just wanted to note that I've had a couple requests in the chat. If you could lean into your mic a little bit more, I don't know if you could turn your mic up or lean in, or basically just be a bit louder. I think you have a quieter voice than I do. And so folks are asking for you to be a little bit louder, if that's okay.
Yes, it's fine.
Thank you. One of the other aspects I know that you talked about a lot in the design team was around the critical role of leadership. We mentioned that in the overview we gave a little bit earlier at the top of the webinar about how important leadership is in creating an aligned system. So it's really leaders that look at those aspects of prevention, case management, targeted services, the use and selection of evidence-based programming, and what that looks like in terms of a service array, and you know, engaging families and all of those pieces. It really takes effective leadership to do that. So since you've talked about this critical role of leadership in the past and in creating an aligned approach for prevention, just kind of wondered if you might talk about what leadership skills you're relying on as you you know, plan for prevention services and continue to support families currently.
Yes, so collaboration is key in addressing the safety of children and families. We knew that prior to the pandemic, with the onset of school closure and less opportunity to have children observed who may be at risk, we, both the child welfare and educational system, began to question our ability to serve children and their families in the way that we have historically. As I take a breath and expand my view, and I hope you are as well, is this a real moment for the two systems in the context of Family First Prevention Services Act to develop real and meaningful programming? As safety is always paramount, is the conversation also about well-being, Is it equally applicable in this occasion in the wake of COVID-19 that we not only partner around physical risk, that we also address the lack of academics during this time? Additionally, the reliance of medical providers as another key lead professional or mandated reporter. How available can they be with the focus of COVID-19? Is there the possibility of slippage? Again, is this a real moment to reflect on how we conduct our shared business of providing services and being available to those who are most at risk?
Thank you so much, Jacqueline. It is so critical, this role of leadership right now, and I think it's something that we're really seeing our leaders and emerging leaders really looking at so many things that are critical to keeping children safe and also to continuing to serve our families. So thank you so much. I have one final kind of planned question, and then I know from there we're going to open it up for some Q&A with everyone on the webinar today. But what I wanted to end with is really thinking about what you have learned during this time about supporting child welfare staff. So, in your agency or just in talking to other leaders, what you've learned about supporting child welfare staff and the families you serve, during this critical time that you will carry with you in a post-pandemic world as we hopefully move to the other side of this, how you will kind of take these learnings and move forward.
Yes, one thing that was clear is around the safety of staff. As a system, we stopped training on the utilization of universal precaution. At the onset of the AIDS crisis, there was significant guidance on how to take proper safety measures. COVID-19 has really helped all individuals to really rethink this practice. Other thoughts I would like to share is the theme of recovery. As we assess COVID-19 in the context of well-being of those we serve going forward, it goes without saying the importance of an integrative health approach addressing both medical and behavioral health, and the importance of healthy social connections. Lastly, I would be remiss if I did not highlight the impact of the pandemic on the African American community. Are we envisioning the implementation of the Family First Prevention Services Act with the creation of programming that counteracts the impact of social issues such as health disparity, poverty, housing, particularly in the context of population density, which resonates with me, particularly now serving in 2 urban jurisdictions, New York City and North Carolina, as Mecklenburg County leads the state with the number of COVID-19 transmissions and deaths.
Thank you so much for lifting up those critical pieces around staff safety, around recovery, and then also really lifting up this issue of shining a spotlight that COVID-19 has really shown, an even greater spotlight on existing disparities. And as we think about prevention, both primary prevention and prevention associated with the Family First Prevention Services Act, it is really critical, and we touched upon some of that as we move through the presentation, but I think it's a conversation we need to have more broadly. So thank you so much for this, and I think we are going to move it to we have about 20 minutes left to have some Q&A with our webinar participants.
Yes, thank you. Thank you, Jacqueline, for taking time away from attending to families and staff, and for your honest assessment of your current challenges. We so appreciate your presence on this webinar. And thanks also to Allison for reminding us that aligning service systems with service delivery produces seamless services for families and can assist them in that path to recovery that Jacqueline was just talking about. So now it's time for some questions from our audience. Remember, you can enter questions in the Q&A window, and we'll try to get to as many as we can. But I have a couple to start with. There was a question about evidence-based practice virtual home visits. How do they currently fit into the way services are delivered? I'm not sure who to toss that to, but Jacqueline, if you have any, I'll start with you. If you have any experience with virtual home visits in Mecklenburg and how those are going and how you can, is there even any evidence base to wrap around those types of visits?
I really can't speak to the evidence-based portion of that, but I can say that we have been utilizing technology more and more to conduct our work with regard to how we assess families. We, again, as I had shared earlier, we are really trying to partner with our families to kind of think through how best to keep everyone safe. So we basically have gone into the field with our smartphones and been creative. And that goes for visitations with regard to ongoing safety assessments as well.
Allison or Leah or Amanda, do you have anything you want to add to that?
Nothing to add. Just in our work with child welfare jurisdictions across the country, we do know that folks are using technology, as Jacqueline said, and doing the best they can and continuing their mission critical work. So it feels like it's an important option.
Thank you. The second question is, are we going to discuss any specific models that are evidence-based? I assume by that the person asking the question means practice models. And I can maybe tee that up in saying that as part of the design team, I think we arrived at a conclusion early on that it would be virtually impossible to make one model, one practice model, solely evidence-based, and that we saw it rather as an umbrella approach with evidence-based practices and programs under it that all were interconnected. Even the daily job of casework we felt could be, say, federally reimbursable as important work toward treating mental health of children and families. So, Allison, why don't I throw that question to you? I know we spent some time not only talking about it, but within the paper itself, defining what we meant by practice model and evidence.
Yeah, sure. And you know, I remember these early conversations, Suzanne, and one of the things that was really important to us in developing the preventive practice model was that we knew that with the legislation, there was a lot of attention around the requirements for evidence-based models. And one of the things that we wanted to make sure of is that we weren't kind of leading with specific models at the expense of developing an aligned approach. And so we knew that aligned approach needed to start with the foundation of prevention, which is case management. And so really thinking about how evidence can undergird case management and how case management can be implemented, you know, with high quality and consistently, just as is required with evidence-based programs. And that from there, thinking about the targeted services that are offered within the jurisdiction to respond to family needs and strengths, and that the evidence-based models was kind of the third part of it, which was that, you know, would families benefit from additional services above and beyond case management and targeted services that were focused on those risk and protective factors. And so we really saw those specific evidence-based models as kind of the third part of the overall practice approach, and that we really wanted to lead with this umbrella approach, as Suzanne is saying, and that we wanted to really lead with case management as the anchor, and that any evidence-based models that are chosen should be chosen in alignment with, so they're theoretically aligned with the approach to case management and aligned with the principles and values that have guided decisions around case management and targeted services in a jurisdiction, rather than just kind of, choosing evidence-based models first and maybe backing into those other parts of the preventive practice model.
Thank you. That's important to note. Leah or Amanda, did you want to weigh in on anything about that?
No, I thought that was perfect.
Yeah, it was a good one. It's a good answer. Very complete. Thank you. All right. Jacqueline mentioned the higher incidence of structural risk factors with family of color, poverty, housing, racism. Does Family First have a way to cover interventions that address those structural factors, like getting families who are candidates due to poverty rather than the housing they need? The concern is that evidence-based practices have tended to be rolled out as a way to fix the family rather than fix the system. And we wondered if you had any thoughts about that, anybody in the group.
So I actually can, I'll start and anyone else can join in. One of the things that is being discussed in North Carolina is an opportunity to kind of use Medicaid dollars differently than we have historically, to really address the issues of some of the challenges that we've seen in the community, redefining how we look at health, the social determinants of health in particular, looking at how do we use dollars to support families around housing, how do we look to also help with regard to violence that they may have experienced. So I do think partnerships, particularly child welfare and public health, probably could do some work together to kind of address our population, particularly the child welfare population, those that come to our attention, which from my experience has been our most vulnerable families out there. So there's opportunities.
Yeah, anybody else?
This is Allison. I just wanted to note too, kind of like a broken record with this, but coming back to the case management piece, as we think about evidence-based case management approaches, I think that it's really important to be looking at how that addresses these types of disparities. And so I think about economic disparities, and so approaches like mobility, mentoring, being, approaches that you can embed into family support frameworks that would really support a family's kind of financial mobility, which is, these are critical aspects of overall prevention, and I think can be used in a more targeted way than aligned with Family First, is I guess what I'm saying. And while a lot of that can happen as part of primary prevention efforts, I do think that there's opportunities within Family First to really think about specific programs that do address disparities. And the one that's coming to mind for me was mobility mentoring, or the and I don't, I'm not a proponent of that particular program, but just saying that it's one that I know of that is focused on economic disparities. So just a thought there.
Thank you. Looking at another question, the question is, I'm on several foster care review boards, and my question is about how we can better share information about problems that families are encountering so that we can understand more about their challenges. Is there a workable format that you know of that systems are using to get family voice in real time, any kind of chat function or any kind of boards that speak to families or allow them a platform to share what they're going through?
And Suzanne, I just want to be clear, did they say foster families or did they say?
Looks like vulnerable families. The person asking the question is on a foster care review board. No, it doesn't look like we have a response. Are there any Well, I could ask you, Jacqueline, how do you communicate with families in general? Is it still be a caseworker family, or are there larger virtual community, maybe town hall formats or something? I would guess that would be a response.
Right, so there's opportunities for both to occur. We do have probably a much more robust supportive type structure, I would say, for our youth than I have seen for our parents. So I do think there's opportunity for us to develop that more. Particularly in this environment. I think, again, and Allison raised this, is that it has been my experience that that voice is going to be important as we define the services through this legislation. We don't want to have that disconnect, and we're developing services that are not necessarily what families feel that they need.
Yeah, I think this is Allison again. I mean, I think just tagging on, Jacqueline, to your comments, you know, a lot of it too comes back to some of the alignment we talk about in a system, and so how we support those feedback loops between families and practitioners and supervisors and managers and leaders, and how visible those feedback loops are and how formally they're set up. And I wondered, Leah, if you might want to comment on kind of our use of teaming structures and how that can sometimes be really beneficial to gathering family voice and using family voice to make decisions.
Yeah, sure. Happy to. I think, you know, one of the things that we've seen work really well is to create a real intentional teaming structure with diverse perspectives. So that would be including family voice and perspective in a meaningful way, and thinking about ways that that would work well with either, you know, families who you have become advocates or worked with in the past and have an interest in participating, and then, you know, just really thinking about and being thoughtful about their participation and supporting their involvement in meaningful ways, and really compensating their time for doing that, I think is really critical for the success of their involvement and participation. And the other thing is, you know, I think this also could aid in some of the questions around some of those larger systems issues. So thinking about, you know, how other system partners may be involved through some sort of teaming structure, like those who may provide supports around, you know, housing for families or economic mobility types of programming, so that there's strong communication within those partners through a teaming approach. So that's just, one strategy to really kind of organize or structure groups and relevant help, partners within the system.
Thanks, Leah. I think we have time for a couple, maybe another question, and then I just wanted to make a comment. We have a request in our chat box for including pediatricians, and the feeling that pediatricians should be included from the very beginning. They are, after all, experts in health and welfare of children, child development, psychological health of children, and should be considered in any development of a practice model. I know when my children were young, we totally relied on our family pediatrician, and so we hear you and would love to have a pediatrician voice in the further development of this practice model. As Allison was saying, that our prevention model is still in development. We still have groups to hear from, and if you would leave some contact information, we'd be more than happy to get in touch with you. Okay, so we have a question about assessment. Now more than ever, it's going to be really important to get the right programs that are cost-effective, that are evidence-based, and that match family need to EBPs. What do you recommend from the beginning, Allison? I believe this question is for you, around putting those assessments in place that can match family and child need right from the beginning?
Sure. So we use something called a hexagon assessment, or a fit and feasibility assessment, as it's called at Casey, that looks at 6 domains of evidence-based programs to ensure that they meet the needs and strengths of the families that you're serving, but also are feasible to implement. So we call it the hexagon model because there are 6 domains, 3 of which are basically program indicators, so the extent to which there is evidence for the program, the types of supports that the program provides. So, the extent to which it provides training and coaching and fidelity assessments, which make it easier to implement. And then how usable the program is. So the extent to which it's been fully operationalized, because there's, certain evidence-based practices or programs that are less defined than others. So all of those 3 pieces, evidence, supports, and usability are things you can really objectively look at around the program. And then on the site side, the other 3 domains that we look at, which we call implementing site indicators, are need, so the extent to which the evidence of that program or practice is directly related to the need of your population. And again, we really strongly recommend, if not require, in the use of the hexagon, the use of disaggregated data, so that we are not misjudging the needs of our population or not understanding the strengths of our population. And then looking at the extent to which we have the capacity to implement. So based on the supports that are provided, we also need to have capacity in-house to ensure that we can sustain the program over time. And then finally, the extent to which the program is a good fit with community and family perception of need, historical aspects of the jurisdiction where things are being implemented, so culture, values, past and current priorities, and to really getting a sense to which it's a good fit. So we have a model, it's open source, you can score and look at a bunch of different evidence-based programs and then make some choices based on the scoring of those 6 domains of what would be the best fit for your jurisdiction.
And how can people access that?
It's available on the NERN website, so people can access it there. I think we can put that in the chat potentially now in the next couple minutes as we're talking. And then if one of us is quick, and we can also send that out afterwards to folks. We can figure out a way to do that with Annie Casey Foundation.
Great. I know there'll be questions about access. So, all right. Thank you again to our presenters and to our audience for your great questions. There were some we couldn't get to. I apologize for that. This brings us to the end of today's webinar. As you see on the slide, you can download our paper at the above address on the aecf.org website, and we also will have the slides and the webinar recording made available next week at aecf.org/webinar. Our next webinar in this series is scheduled for July 22nd, and will focus on understanding and planning for the fiscal impact of Family First. Margaret Flynn-Kahn, whom you've heard before, will talk about what it takes to develop a realistic budget estimate for evidence-based programs that includes costs that are unique to the child welfare system, help in the projecting of staffing and contracted resources that would be needed to effectively administer prevention services. The registration will follow shortly for that, so look out for it. We hope today that we've provided some ideas for planning what comes next and helping you steer your work. We know that the commitment to safety, permanency, and well-being is and always will be strong, even in these difficult times. Thank you so much for your interest and for your attention today.